Hi, this is Jeff Hesselup. I'm an interventional cardiologist at St. Alphonsus Regional Medical Center in Boise, and I wanted to briefly discuss the current SEAI guidelines for the management of pain foramen valley. You can get the full text on the SEAI website, and you can have more details about what we're going to discuss today. I mainly wanted to discuss a brief introduction to the subject and why we may recommend closure versus not recommend closure for somebody's PFO. The first thing to mention is that a patent foramen valley is very common. About 25% of the population has a patent foramen valley, and it's associated with certain syndromes listed here. Most people go their whole lives, don't realize they have a patent foramen valley, and there are no negative effects from having it. There are a select few patients who have problems, including paradoxical embolism and stroke. Slide shows two TE images. On the left is a TE demonstrating a patent foramen valley. You can see there's a uh, really mobile intraatrial septum there. There's evidence that it's opening during the cardiac cycle. Sometimes we don't see the septum opening like this. We rely on a bubble study. On the right image, however, you can see there's a complete lack of tissue in between the two atria. For patients with ASDs, they don't necessarily need a paradoxical embolism to be closed. There's other criteria to close an ASD, which I won't discuss here. But if they do have an ASD and a paradoxical embolism, we would consider closure as well. We regularly get imaging studies to convince ourselves that a paradoxical embolism occurred. This includes a non-contrast MRI of the brain and a CT angiogram of the head and neck vessels. This rules out, it rules in a stroke, first of all, in the MRI of the brain. It also rules out vascular disease as the cause of a stroke. We want a cardiac event monitor, minimum 2 to 4 weeks. If they're older, I'll go beyond 4 weeks just to convince ourselves that we have not missed atrial fibrillation. We get a hypercoagulable workup routinely on people. Minimally includes a workup to make sure there's no antiphospholipid antibodies present. A family history can also give us clues if they have a hypercoagulable state. A TE is generally the most common way we can find the presence of a PFO. It's a good screening tool. A little more sensitive but slightly less specific would be a transcranial Doppler. Duplex ultrasound of the lower extremities to look for the presence of a DVT. This would build our case that a paradoxical embolism would occur. We also would consider doing a TEE if there was no PFO seen on the initial study, or if we wanted clarification more specifically to the septal anatomy. The team is convinced that paradoxical embolism has occurred and would explain the stroke that they had. If they're young, we have a strong recommendation for closure. There's some features that make it more likely that a paradoxical embolism occurs. This is encompassed in part by the rope score. But in general, if a PFO is present and it would explain the stroke they had, that we generally recommend closure for younger people. If you're over the age of 60, it's a conditional suggestion. There is an uncertain benefit. We just don't have the data for this age group yet. But many people elect to have PFO closure after a shared decision-making discussion. There are certain medical conditions specifically mentioned in the guidelines, including thrombophilia. Again, if a paradoxical embolism has occurred and people are more likely to clot, it is recommended that they have PFO closure over medical therapy alone. Atrial fibrillation is a condition in which PFO closure is not recommended generally. If someone is found to have atrial fibrillation, they would be treated with anticoagulation primarily. And then there isn't really a recommendation about the time interval. If somebody comes to me and says, well, my stroke was 4 or 5 years ago, um, we don't take that into consideration. Mentioned in the guidelines are non-stroke indications for PFO closure. These have been studied limitedly. Migraine headaches is one of them where we have anecdotally seen a benefit. However, this has not been borne out in clinical trials. There's some limited evidence that patients with frequent migraine with aura would uh, benefit, but we don't have the data to really um, recommend that they have it done routinely. There is some limited data to suggest there's some benefit. There's also data to suggest that it doesn't make a difference. Platypnea orthodeoxys syndrome, positional or exertional hypoxemia that's proven, and other conditions have been ruled out that would be causes of hypoxemia. Again, this um, has some degree of uncertainty, and we certainly have that conversation with patients that it may help or there may not be a benefit. Systemic embolism is one of those things that I kind of treat like stroke. I rule out other causes of systemic embolism, definitely a hypercoagulable workup, and usually we'll offer closure if I'm convinced that it's paradoxical embolism that's the cause. So in general, PFO closure is recommended patients with image-proven ischemic stroke or systemic embolism. Things like platypnea orthodeoxys syndrome can be recommended to close that, but we have to be very convinced that that's the reason for the hypoxemia with everything else ruled out. And patients with vascular disease and atrial fibrillation, we usually recommend against closure for lack of benefit. If you have any questions about a specific patient or need to talk, I'm available through Epic. You can send me a message there. I'd be happy to get back to you and review your patient's case. Thanks.